All right. Well, hello, everyone. Happy Monday. Hope everybody's doing well today. Thank you for being here and joining us for our Monday Grand Rounds. We have a couple of really awesome speakers. Really excited to hear their presentations this morning. To start with, we have one of our second years, Cole Papakirikos, who comes to us originally from Fitchburg, Massachusetts. He did his undergrad at Cornell and did medical school at the New York Medical College. Cole is going to be presenting our Grand Rounds warm-up talk for the first 10 minutes this morning, and he's going to be discussing the sideline concussion assessment. So Cole, thanks for being here. With that, I will pass it over to you, and you can go ahead and share your slides and take it away.
All right, thank you, Sam. Let me just full screen this. All right, so I have no disclosures to give you guys today, and my learning objectives, I think, were sent out by Kathy earlier, but they are to identify common signs and symptoms of concussion, define risk factors for concussions, and understand the utility and limitations of sideline tests in diagnosis and management of concussions. So I wanted to start off pretty general and just give a brief definition of concussions, which is a pathophysiological process affecting the brain induced by direct or indirect biomechanical forces. It involves a rapid onset of usually short-lived neurological impairment, which typically spontaneously resolves. The acute clinical symptoms usually reflect a functional disturbance rather than a structural one. And overall, there are about 3.8 million recreational and sports-related concussions each year. Between 1.1 and 1.9 million of them are estimated to be children under the age of 18. The highest incidences occur in tackle football, girls soccer, boys lacrosse, and boys ice hockey. In comparable sports such as women's soccer, girls have a higher concussion rate. And a risk factor is ADHD. A common risk factor is ADHD, which makes you more prone. Sports-related concussions are considered some of the most complex injuries in sports medicine to diagnose and manage. The majority of concussions occur without loss of conscious or frank neurological signs. The symptoms range broadly, as appearing on this slide, from headache, photophobia, balance problems, to more subjective symptoms such as feeling irritable or feeling like you're in a quote-unquote fog. The diagnosis is challenging to clinicians because it not only involves recognizing symptoms, but also adhering to the objective assessments and enforcing return to play recommendations. Unfortunately, at present, there's no perfect diagnostic test or marker that clinicians can rely on for immediate diagnosis on the field. But we will review some of the more current methods with this presentation. Originally introduced in 1997, the Standard Assessment of Concussion, abbreviated to SCAT, has evolved to include multiple tests and assessments to aid in the identification of concussions. This is a consensus-based instrument validated for use on sidelines to evaluate athletes greater than 13. The most up-to-date version of this test is known as the SCAT-5 and was published in 2017. There are multiple steps in the assessment that are divided into an on-field and off-field section. On-field evaluations assess red flags or patients who require emergent medical attention and stabilization, followed by observed signs from the trainer or provider assessing a memory assessment and establishing a GCS or C-spine assessment. Once the player is removed from the play, they are further assessed with a symptom evaluation, cognitive screen, and neurological screen with a delayed recall assessment. The test is initially taken when athletes are in their well state to determine a baseline for certain portions of the test. While this test is, as I mentioned before, is used for athletes greater than 13, there is a separate test known as the Child SCAT-5, which is used for kids aged 5 to 12. The test removes items that are difficult for young kids at baseline, like standing on one leg or reading words out loud. There's also a parent section in this test. One of the components of the SCAT-5 is the Standard Assessment of Concussion. It assesses mental status across 4 domains: orientation, immediate memory, concentration, and delayed recall. The test is scored out of 30 points, and each error removes a point from the score. Immediate post-injury athletes can drop, on average, 2.9 points below their baseline. A 1-point drop from baseline is associated with a 76% sensitivity for diagnosing concussion. A separate section, the post-concussion symptom scale, is another section of the off-field assessment that reviews 22 symptoms and asks an athlete to denote the severity from 0 being the most mild or not present to 6 being the most severe. This test has a 79% sensitivity for concussion and has a wide variability amongst individuals and should not be used in isolation. Two other sections on the SCAT include the Balance Error Scoring System, BESS. It is issued to evaluate postural stability in order to help diagnose concussion. This test relies on the judgment of the provider and is made up of 3 stances: the double leg, single leg, and heel to toe tandem. They must be maintained for 20 seconds with their eyes closed. Errors are classified as opening eyes, removing hands from the hips, stepping or falling, foot lifting, failing to return to the test position for less than 5 seconds. The test is scored by adding each error for a max score of 60. A separate test, the tandem gait testing, is another balance test that is sometimes used for balance assessment, for the balance assessment portion of the SCAT. This test assesses locomotion, dynamic balance, and lower limb coordination. Athletes heel to toe walk quickly and accurately along a 38 millimeter wide and 3 meter long tape. The best of 4 time trials is the final score. This test has a sensitivity of 61%. This test is preferred over the BESS in some cases as it has less impact from exercise fatigue. Overall, this assessment has an 83 to 96% sensitivity and 81 to 91% specificity. It assists providers in diagnosing concussions and helps limit the subjective interpretation from examiners. The goal of these assessments is not to miss a potentially concussed player and minimize the immediate risk and risk of secondary injury to players. Unfortunately, the tests are limited. There is no official subscore cutoff that would indicate significant change from baseline. Additionally, the test has demonstrated its largest effect when used less than 24 hours after an injury. While SCAT testing is the most common sideline assessment, there remains one additional test with conclusive efficacy, the King-Devic test. This test assesses the visual pathways of a player by measuring the speed at which athletes read 120 numbers as depicted on the screen from 3 test cards of increasing difficulty. The score is summed from the total time reading cards and number of errors. This test has multiple advantages. It is easy to administer, portable, and takes only 2 minutes. Additionally, it was found that there is no difference in scores when administered by a layperson versus a provider. These advantages, combined with its high sensitivity of 86%, have led it to be more increasingly used as an adjunct tool for sideline testing. While the SCAT and King-Devic tests are the only 2 sideline assessments with conclusive efficacy, there are many with limited data that could be helpful in the future. Here are some examples listed on the slide. Head impact sensors, which use accelerometers to calculate linear and rotational acceleration, are a possible future use. These measure and calculate force of the impact in each player. There is variation in an athlete's threshold for concussive injury, and therefore more work is needed to validate its use. There is vestibular ocular screening, which measures responses to vestibular ocular symptom provocation, but these tests still need more validation. There are multiple mobile and tablet applications, but the most famous of which is the immediate post-concussive assessment and cognitive testing, otherwise abbreviated to IMPACT. This is an FDA-approved assessment of concussion using an installed online app. It requires 20 to 25 minutes, a baseline test, and post-injury assessment. This test has been assessed and has a sensitivity of 82 to 91%. While it has been assessed, it is not considered a true sideline test, as subjects are assessed and after removal from play. There is a quick test that can be administered rapidly on the sideline, but more research is needed to validate it. Overall, some take-home points I just wanted you guys to go home with are: concussions are common health risks to young athletes, and diagnosis is difficult for sideline providers. The SCAT test can be used to identify these concussions and limit the bias from the provider. There are many future directions for sideline testing, and hopefully one day we'll see on-helmet sensors and apps that can be used on the sideline. That's all I have. These are my references. If there are not any questions, I'll turn it back over to Sam.
All right. Thank you so much, Cole, for an interesting talk. A great choice for a resident with interest in sports medicine fellowship after completing pediatric residency. With that, I will change gears and move to the body of our Grand Rounds talk today. So I am really pleased to introduce today's Grand Rounds speaker. Today we have Dr. Rita Mangione-Smith. Dr. Mangione-Smith completed her undergrad studies at the University of Michigan and subsequently earned her MD from the Wayne State University School of Medicine and an MPH from the University of California, Los Angeles School of Public Health. She completed residency in pediatrics at Children's Memorial Medical Center of Northwestern University, where she also served as a chief resident prior to a Robert Wood Johnson Clinical Scholars Program fellowship at UCLA. Dr. Mangione-Smith is currently Vice President for Research and Healthcare Innovation at Kaiser Permanente, Washington, and Executive Director and Senior Investigator with the Kaiser Permanente Washington Health Research Institute. She's a professor of health system science at Kaiser Permanente School of Medicine and an affiliated professor at the University of Washington. Dr. Mangione-Smith's research has focused on assessing quality of care and developing, evaluating, and implementing quality improvement interventions. She has conducted extensive research on doctor-parent communication, including how interactions influence antibiotic prescribing for acute respiratory illness, and has developed a quality improvement intervention for outpatient providers called Dialogue Around Respiratory Illness Treatment, which we will learn about today. I will say that we were really excited to have Dr. Mangione-Smith, and particularly one of our co-chiefs, Jeanette Beaudry, who, as many of you know, is an infectious diseases fellow when she's not a chief resident. And we're really excited to hear your talk today, Dr. Mangione-Smith. So thank you so much for being here. And with that, I will turn it over to you for your Grand Rounds presentation.
Great. Thank you so much for that very kind introduction. I'm thrilled to be here with you today. And as Sam mentioned, I'll be talking about the Dialogue Around Respiratory Illness Treatment QI intervention that I developed with colleagues based over about 15, 20 years of preliminary studies that we did. So it was a long time coming, and I want to share that journey with you this morning. And so I have nothing to disclose. So just to give you a little outline of what I'm going to talk about with you, I want to start out by reviewing what we know from prior research around doctor-parent communication in this realm, both from our work and from the work of others. I then want to review the components of the DART QI program. And then I want to share with you a little bit of the content from that program. We're going to view some DART QI program video examples that we use to actually train providers when they go through the QI program. I'm going to then go over some of the key results from our trial where we tested the effectiveness of DART in reducing outpatient antibiotic prescribing for respiratory infection. And then I will try very hard to stay on time and leave some time for questions and discussion. So what do we know from prior survey research? Well, we know that many parents come to visits for their child's acute respiratory infections expecting antibiotics, and that can range anywhere from 50 to 70% depending on the study you look at. When we as healthcare providers perceive that a parent wants an antibiotic, we're unfortunately significantly more likely to inappropriately prescribe. So today, I'm going to share with you what my research group has learned over the past couple of decades by carefully analyzing over 600 videotaped visits that were accompanied with survey data that we collected during actual office visits for pediatric acute respiratory infection. By doing that detailed analysis, we've learned which communication practices really work best to increase satisfaction with care, decrease unnecessary antibiotic prescribing, and shorten visit lengths. So some of our key findings include that, first of all, the way parents communicate during visits for their child's acute respiratory infection strongly influences whether you and I come out of that visit believing that they want an antibiotic. And as I mentioned before, when we believe a parent wants an antibiotic, we're unfortunately significantly more likely to give them, even when we believe the infection is likely to be viral. But good news is, we have identified some really effective communication strategies that we can use to successfully manage that perceived pressure to prescribe and at the same time maintain satisfaction with care. So what do we know from our communication research? Interestingly, although I told you 50 to 70% of parents come in expecting an antibiotic when they bring their child in with acute respiratory tract infection symptoms, they rarely directly ask for them. So in those 600 some odd visits that we analyzed in detail, that a direct request for antibiotics happened less than 5% of the time. But managing those expectations is obviously important to avoid unwarranted prescribing. So then if they're not directly asking for them, what do parents do? What they commonly do is they indirectly communicate to us so that we perceive them as expecting antibiotics. How do they do that? And some of this may feel a little bit familiar to you if you've been in that exam room with a parent who does these things. So one of the places where parents commonly indirectly communicate their expectations for antibiotics is during the presentation of their child's problem. So when you're collecting that HPI. And one type of problem presentation that they commonly use when they expect antibiotics is called a candidate diagnosis. So what is a candidate diagnosis? Well, they can be explicit, where a parent actually names the potential diagnosis that they think their child has. So here's an example from our data. I'm really worried that she might be coming down with bronchitis. Or it can be implicit, where the parent describes symptoms in a way that clearly implies a particular diagnosis. So the stuff coming out of her nose just won't quit, and it's getting really thick and green, connoting the parent probably thinks their child has sinusitis. Or can assert that someone else in the family or another kid that their child has been exposed to at school had an antibiotic relevant diagnosis like sinus infection or strep throat. So an example from our data, I've heard that a bunch of kids in this class have been out sick with strep throat. So it's when you hear those candidate diagnoses, that is a red flag. Parents who use those candidate diagnoses compared to parents who don't are 25% more likely to expect antibiotics for their child. And like I mentioned, there are communication strategies you can use to successfully manage those expectations that you're perceiving. And it turns out how you manage that treatment phase of your visit, the very last phase of the visit, and how you structure your treatment recommendations is really important. I'm going to go over 4 key things that we teach in the DART QI program that providers should do during that last phase of the visit. The first 2 are review your physical exam findings and deliver a clear diagnosis. So why do we have to sit down and go over our physical exam with parents? What it does is it's making the case for your diagnosis. So when you perceive parents as expecting antibiotics for their child, you can decrease unwarranted prescribing by doing the following. His ears look good, his lungs sound great, no ear infection or signs of pneumonia. His nose is pretty congested though, and his throat is a little red, but nothing concerning for strep. So what has the provider done here in this example? They've basically taken the parent down by the hand and they are leading them down the path towards a viral diagnosis. They're kind of making the case that, I've carefully examined your child. Here are the objective things that I'm seeing. And it's kind of preparing them then for the diagnosis statement. Now, it's really important that you make a clear diagnosis statement. Many times in the visits that we analyzed, we saw providers, and I've done this myself, where you say, this is just a virus, nothing to worry about, it'll go away by itself. Or, he's got the bug that's going around. We're seeing a lot of this. That actually doesn't count as a diagnosis. But fortunately, telling somebody their child has a cold count as a diagnosis and is interpreted as a diagnosis by parents. So simply saying what we have here is a really bad cold is way better than saying this is just a virus. Okay. The next, and I think probably the key thing that we really want to focus on is how we do our treatment recommendations. And what we do is we recommend using a two-part negative positive treatment recommendation. So what does the evidence tell us about treatment recommendations? There are two main ways that we as providers tend to recommend treatment for acute respiratory infections. We use negative treatment recommendations where we rule out the need for antibiotics. So we say, this is just a cold, nothing an antibiotic will touch, okay? The second type of recommendations we tend to give are for symptomatic relief or positive treatment recommendations. So raising the head of her bed will help with the drainage from her nose when she's sleeping so she won't cough so much. So parents, we also know from prior research, generally expect to get advice on how to help their child feel better, how to deal with the symptoms their children have been having all night. And they're really frustrated when we only recommend that no treatment is needed. So it turns out that using those negative treatment recommendations on their own, where you rule out antibiotics, is not a good strategy. It increases parent questioning of your treatment plan. And what does that do? It shifts us from provider decision-making to provider-parent negotiation over treatment. It increases the probability that you'll get frustrated and give in and give an unwarranted prescription. And it extends visit length, because what it forces us to do is to re-explain why we're not giving antibiotics. Okay, so, we kind of saw this in some of our earlier studies, and we decided the next study we wanted to do, we really wanted to understand the treatment recommendation period is clearly critical for this research. And we wanted to understand, okay, so if you shouldn't just give a negative treatment recommendation, should you never give them? Should you only give positive recommendations? How about if, you give them both? And if you did do that, which one should go first? And so we did another video analysis of a separate set of visits and specifically looking at this question. And what we found was pretty straightforward. When combined, a negative treatment recommendation followed by a positive one had the lowest association with unwarranted prescribing, strongest association with higher parent satisfaction, and shorter visit lengths. We really considered that a win-win outcome. So it turns out how you lay out your overall treatment recommendation is really important. And what we recommend in the DART QI program, and based on our research, is always leading with a negative and ending with a positive treatment recommendation. Now, you may be sitting there saying, wait a minute, didn't you just tell me that if I use a negative treatment recommendation, the parent's going to question me and it's going to lead to, a negotiation and decreased satisfaction? Yes, I did. So it's really important to not provide an open space for parents to respond to the negative part of your treatment recommendation. Well, how do you do that? What we recommend is you use something we call the on the one hand, on the other hand structure for giving your treatment recommendation. So on the one hand, antibiotics won't help them get better. That's the negative treatment recommendation. But on the other hand, there are lots of things you can do to help with the symptoms, like giving him a teaspoon of honey before bedtime to help with the cough, the positive treatment recommendation. It turns out that the English language is really interesting in this way. When we hear somebody say, on the one hand, we will wait until they tell us what's on the other hand before we interrupt, almost 100% of the time. We saw providers do this over and over again successfully in our video data. The other technique we saw that works similarly is the bad news is an antibiotic won't touch this. The good news is there's lots of things you can do to make them feel better. We don't tend to teach using that methodology because as somebody who's interested in antibiotic stewardship, I never like to say that not getting an antibiotic is a bad thing. So, but that's just an aside. Both of them work in the same way to decrease the likelihood that parents are going to interrupt and question the negative part of the treatment recommendation. Okay, the fourth and final key communication strategy I want to cover with you that we go over in the DART program is providing a contingency plan. So what is a contingency plan? It's basically a really nice, solid follow-up plan for the parent, where basically, if you're not going to give an antibiotic, what you're telling the parent is what to watch for over the next few days and when to recontact you, because treatment might change. And that recontact can certainly be by telephone, now video visit, or a return visit. Definitely call me if she starts having high fevers or is having a hard time catching her breath. I don't expect that to happen, but that's what you should watch for. So we did an analysis years ago looking at the provision of contingency plans and how they influence satisfaction with care. And we specifically looked at the group of parents who came in and told us on survey they expected to receive an antibiotic for their child, but left without an antibiotic prescription. And what you're looking at on this score is here's satisfaction score from worst visit ever, the best visit ever on the y-axis. And then down here on the x-axis, you have, yes, a contingency plan was provided, and no, it wasn't. And so what happens with this group of parents who came in expecting an antibiotic and not getting it, but they do get a contingency plan? Satisfaction's a little bit depressed. It's not up there in the 90s like we often see in outpatient visits, but it's at 76. Okay, so what if we have a parent in that same situation and we don't give a good follow-up plan or contingency plan? It drops a full, almost a full 20 points, not quite, but down to 59. Obviously a statistically significant drop on this scale. So the bottom line message here is that if you've got a parent who expects an antibiotic, you're going to hold your ground and not give it. Giving a really good contingency plan goes a long way to maintaining satisfaction with care. I want to pivot just a little bit here now and talk about what the DART QI program components are. So DART was developed based on all of that previous preliminary observational work that I just shared with you, and studies that were completed by Jeff Gerber and his colleagues at Children's Hospital of Philadelphia, where they did some really elegant work looking at individualized antibiotic prescribing feedback reports and how that influenced prescribing over time. Together we developed this distance learning quality improvement program that's delivered over 11 months, kind of little spurts consistently over an 11-month period. And what it includes are 2 online tutorials, one on communication strategies and one on evidence-based prescribing for ARTIs. And then we do 2 live webinars that the providers involved in the program can either attend live, or if they can't do that, they can watch the recorded webinar. And during those webinars, we're really pulling out some of the key messaging from the communication strategy tutorial and the evidence-based antibiotic prescribing tutorial. We also received 4 antibiotic prescribing feedback reports, very similar to the ones that Jeff and his colleagues developed for their study. And then we also developed 3 online video vignettes, which we called communication booster sessions. And then after you watch a brief video, there's some questions, knowledge questions that you answer. It takes about 10 minutes each time you do a booster. Now, you're not meant to read this. I apologize for the small print, but I wanted you to see what do the feedback reports look like when we email them to providers. They have a little antibiotic tip a month, and basically showing the provider, here's your prescribing compared to your practice, everybody in your practice, compared to the goal that we've set for the DART QI program. And you can see we give them information about how often are you doing broad spectrum prescribing for acute otitis media, sinusitis, and strep. And then for pharyngitis overall, so not necessarily strep pharyngitis, how often are you prescribing? And then for viral ARTI, which we consider URI and bronchitis fall into, and then overall for all 5 conditions. And then we're cautious to tell them how we are developing the metrics, because we find that often providers will ask, I don't believe this data. How did you calculate it? And this helps us show them how we're using their EHR data to calculate the various numbers that we're showing them. Okay, I want to move on to sharing with you some of the DART videos, teaching videos that we use during the webinar to emphasize some of the communication content that I was just talking about. So first, let's look and see what happens when you only give a negative treatment recommendation.
So he's got a virus, not much we can do about that.
But don't you think it might be bronchitis? His cough is so chesty.
Well, even if it is, antibiotics won't help. You just have to wait it out.
That's interesting. Whenever I have bronchitis going on, my doctor prescribes an antibiotic. So I'm a little bit surprised to hear you say that.
Well, it can be a different process in adults, but even for adults, antibiotics really don't help.
So there's nothing we can do about this terrible cough? I mean, he hasn't really been sleeping well.
Not really. The over-the-counter stuff isn't very helpful, and I wouldn't want to put him on codeine or anything.
So I just guess we hope this gets better?
Yeah, it's a little frustrating, but I'm sure he'll be better soon. It's nothing too serious.
Okay, so let's talk about what's happened there. So you notice she didn't summarize her exam findings at all, and she starts out by giving a really vague diagnosis. So he's got a virus. He then goes on to only provide a negative treatment recommendation. Not much we can do about that. So mom challenges the treatment plan by questioning the diagnosis. But don't you think it might be bronchitis? His cough is so chesty. Now, the doctor hears that candidate diagnosis of bronchitis as an indirect request for antibiotics, even though the mom never said the word antibiotics, and provides a second standalone negative treatment recommendation. Even if it is, antibiotics won't help. You just have to wait it out. So mom continues to question and challenge the treatment plan, talking about her own treatment as an adult when she has bronchitis. And that cycle continues and escalates. So what does that do? It wastes time. It leads to negotiation, which you were starting to see happen. And parents generally after a visit like that are going to be really dissatisfied. Nobody feels good, but usually after a visit like that. Okay. Let's look at a different example. What happens when you give a positive treatment recommendation first?
So what can I do for you today?
Well, Anna's been under the weather the past few days. She has a sore throat and she's developed a really nasty cough. Oh, and she's been complaining a lot about body aches.
Oh dear. How long has this been going on for?
About 5 days.
So Anna, this doesn't sound like fun.
No,
Is your throat still sore?
not as much as it was, but it still hurts a lot when I cough.
Hurts when you cough. Any fever at all?
No fever, but she does have these body aches.
Is she eating?
Yes.
Any diarrhea or vomiting?
No.
Okay, Anna, well, let's take a look at you, okay? So what we have here is a really bad cold, and maybe even a touch of the flu.
Oh, I had a feeling, especially with the body aches she's been having.
What I want you to do to make her feel more comfortable is give her some children's Advil every 6 to 8 hours.
Okay.
And I'd also like you to give her some herbal tea with about 1 teaspoonful of honey, and that'll help with the cough. And you should start feeling better in the next 2 or 3 days.
Okay, we'll give that a try. Should I keep her home from school?
That might be sensible while she's dealing with the symptoms.
What about antibiotics? Could they help her get better faster?
Well, her infection is a viral one, and actually antibiotics won't help with that.
I see. She's had these kind of symptoms before and been prescribed antibiotics, so I did kind of wonder about that.
Just stick with the children's Advil and the herbal tea with honey, and I expect she'll feel better in the next 2 or 3 days. Now, if she's not feeling better in 2 or 3 days or things start getting worse, I want you to give me a call and come back in and see me, okay?
All right. Thank you, doctor.
Okay, let's kind of talk about what happened there. So he didn't summarize physical exam findings, but he did give a very clear diagnosis. What we have here is a really bad cold. And then he goes on to give a really nice positive treatment recommendation. And what does the mom do? So mom pursues treatment with a procedural question. So, okay, we'll give that a try. Should I keep her home from school? And the doctor says, yeah, that's sensible while she's having symptoms. But mom still isn't done yet, and she continues to pursue treatment by effectively requesting an antibiotic, which then means the doctor has to go back and do some explaining to defend why he's not giving an antibiotic. Doesn't hugely lengthen the visit, but it does lengthen it, and so it has a little bit more negotiation going on. Okay, so what happens when you start with a negative and end with a positive treatment recommendation, what we generally recommend in the DART QI program?
So what's going on with David?
Well, Dr. Thomas, he's been super stuffy all week, and now the stuff coming out of his nose is getting really thick, and it's turning that dark yellow-green color. So we just thought it was time to have you take a look at him.
Okay. How about any other symptoms, cough or fever?
Oh, well, he has been coughing quite a bit, mostly at nighttime.
Okay. How about any fever?
No, no fever. Well, Dave, have you had any fevers?
I don't know. You should ask Mom.
That's okay. You don't have one now, which is good. Let's take a look at you, sir. Well, he is congested, but the important thing is that his lungs sound fine and his ears look good. His throat is a little bit red, but it's nothing to be concerned about. So it looks like he has a yucky cold. On the one hand, there's no medicine that'll make it go away. Having yellow-green mucus doesn't mean he has a bacterial infection, so antibiotics won't help. On the other hand, there are a bunch of things you can do to make him feel better.
Okay.
First thing is lots of fluids and lots of rest. Raising his head at night can help drain some of his congestion, so you might give him another pillow. You can also run a humidifier in his bedroom at night, which can help loosen the congestion. And a teaspoon of honey can help his cough.
All right.
Now, he should start feeling better in the next 3 or 4 days, but don't be surprised if the stuffiness and the cough stick around for a week or so. That's normal. But I do want to hear back from you if he doesn't start seeming better, or if he starts to get worse, like he gets a fever over 101, or if he starts having trouble with his breathing.
All right. Well, thanks for letting us know he's basically okay.
Well, colds are never fun, but he should be fine.
Okay. Thanks, Dr. Thomas.
Okay, let's talk about this one. So she does a really nice job of going through her physical exam finding with the dad and her patient, and then she gives a nice clear diagnosis. So it looks like he has a yucky cold. He then goes on to give a negative treatment recommendation about there's no medicine that'll help it go away. Yellow-green mucus doesn't mean it's bacterial, so antibiotics won't help. Importantly, she starts with on the one hand, which foreshadows more is coming and prevents the dad from jumping in and questioning her treatment recommendation that's negative. She then goes on and continues to foreshadow that positive treatment recommendation is coming. On the other hand, there's a bunch of things you can do to make him feel better. And you notice dad waits for it and she gives a positive treatment recommendation. And that accepts that with really no further pursuit. So what I want to do is just then kind of review, putting it all together, what we recommend for DART in the communication strategy wise. So when you've got a parent who you believe expects antibiotics and you're convinced this is a viral diagnosis, keep in mind that that treatment phase of the visit, we think of as like one package comprising 4 key communication parts. We want you to review your physical exam findings to make the case for your diagnosis. Grab the parent by the hand and lead them down the viral path. Then deliver a clear diagnosis, deliver a 2-part treatment recommendation, the negative recommendation followed by the positive one, using that on the one hand, on the other hand structure, and then providing a contingency plan. Okay, so you might be wondering, does the DART QI program actually reduce antibiotic prescribing? We wanted to know that too. So we were funded by NICHD to do a trial of the program. The design of our study was a stepped wedge randomized controlled trial where practices were randomized to one of 4 wedges. And when the wedge you were assigned to determined when you started the QI program, and while you were waiting to start, you were in the control condition. So who participated? We did this study in collaboration with the American Academy of Pediatrics Pediatric and Research Office Settings Network, as well as the North Shore Health Systems Pediatric Research Network. And it was 19 practices among those two groups. 57 providers from those 19 practices participated, and we didn't have to have all providers in a practice participate for that practice to be able to be in the study, because as you've noticed, this is a really provider level intervention, not a practice level intervention. Although all the providers in a practice could opt to participate together. So as I mentioned earlier, there's the QI intervention is delivered over an 11-month period, and it's done in 3 program modules. Each of those lasts about 3 months with about a month in between modules. Module 1, they start out by getting a baseline antibiotic prescribing feedback report like the one I showed you earlier. They then get access to our 2 online tutorials, the one on evidence-based prescribing and the one on evidence-based communication practices. And then the following month, they're invited to the webinars or can watch them recorded. Again, one on evidence-based antibiotic prescribing and one on evidence-based communication practices. So although this content is given over 3 months, you can see the actual time to participate is not very much. Then have a month off, and then they start module 2, where we give them another antibiotic prescribing feedback report. And then during that 3-month period, they also are given access to 2 online booster video vignettes to review evidence-based communication practices. So they'd watch a video similar to what I just showed you examples of today, and then they would answer a few questions to assess their knowledge about what went well and what didn't go well during the visit. Module 3, they get a 3rd feedback report. They do another online booster video vignette, and then they get a final feedback report, and then their participation in the program is completed. So just to look at what the study design looks like graphically, here on the y-axis, you see the different wedges that practices and the providers within those practices were randomized to. And then each practice or each provider goes through a baseline period where we take baseline electronic health record data, looking at prescribing for the 5 key conditions. We then go through modules 1, 2, and 3. And then there's a post-intervention period where we continue to follow prescribing. And you'll notice in a step wedge design, if you're in wedge 1, we have less baseline data for you and more post-intervention data. Whereas if you're in wedge 4, we have a lot more baseline data, but less post-intervention data. Okay, so what were our study objectives? We wanted to evaluate the effectiveness of the DART QI program for decreasing acute respiratory tract infection prescribing rates overall for the 5 ARTI diagnoses together. We were also interested in understanding how it decreased prescribing for viral ARTI, and whether it decreased overall prescribing when pharyngitis was diagnosed, not necessarily strep pharyngitis. When you give an ICD-10 code of pharyngitis and you don't code it as strep, our expectation is that strep is probably out there in about 25% of cases. So we would hope that prescribing for pharyngitis diagnoses would not be much higher than 25 or 30%. We also wanted to understand the effectiveness of the program for decreasing broad spectrum prescribing for bacterial ARTIs. And those included acute otitis media, strep pharyngitis, and sinusitis. And you can see how we described narrow prescribing. For AOM, it was amoxicillin. For strep, it was amoxicillin or penicillin. And for sinusitis, it was amoxicillin or Augmentin. So our unit of analysis for the study was patient encounters that were eligible. We analyzed those encounters in 3 different ways. We did the classical intention to treat analysis, where we took eligible encounters for all of the 57 enrolled providers, regardless of their level of engagement in the DART QI program. Now, keep in mind, because the DART QI program is largely an online program, we know when people have looked at opened up the tutorials, how long they've looked at them. We know when they've attended the online webinars, or whether they've watched a full recording or only part of a recording. And we know when they've opened booster video vignettes and whether or not they've answered questions. So we had a really good way of monitoring whether people were really engaging with the intervention or not. Now, the last part was we emailed them those feedback reports. We didn't have a way to know whether that actually opened the report, but we know they at least received it. So we did a sensitivity analysis where we looked at compliers, which we defined as providers who were enrolled who did all or most of the intervention components. And that was about 74% of our providers completed all 3 DART program modules. And then there were the non-compliers who only received, and we hope reviewed, their antibiotic prescribing feedback reports, but really didn't do any of the other intervention pieces. So we compared in our analysis the probability of prescribing antibiotics between intervention and controlled providers, so those who had begun the DART QI program versus those who were waiting to begin it, at 3 different times, during Module 1, 2, and 3. And then we also assessed if there were any observed decreases, whether in antibiotic prescribing, were they sustained after the intervention. For our adjusted analyses, we controlled for things we know influence prescribing decisions, so child age, sex, race, ethnicity, medical complexity, whether or not it was flu season. And then we clustered our analyses on provider, because we know as providers, we tend to do the same things over and over again, and we're more like ourselves than we are like our colleagues. And same thing with practices. Providers within a practice are more likely to practice like each other rather than like providers in a different practice. So we also did adjusted for clustering by practice. So we had 30,872 children who had eligible visits during our study, our 2.5-year study period. Their average age was about 4. About half of them were female. 61% were white, 21% were Hispanic ethnicity, and not surprisingly, most of them had either had no chronic disease or had non-complex chronic disease. Now, those 30,872 children actually had 83,195 eligible encounters during the study. And you can see that viral ARTIs were the most common, 41%, followed by pharyngitis, about another 20,000 diagnoses. And among the pharyngitis diagnoses, about a third were strep pharyngitis. And then the remaining diagnoses were acute otitis media and sinusitis. I want to orient you to this graphic because you're going to see several of the same graphics. So this is our intention to treat analysis. And what you're looking at here on the y-axis is the adjusted relative risk of prescribing. So what is the probability that you prescribed? And in this case, it's for all ARTI. Now, what is this line up here? The 1.0 line in this analysis is basically how we determine significant increases or decreases in prescribing. If the point estimate and the 95% confidence intervals do not cross that 1.0 line, there was a significant decrease in the probability of prescribing. If the point estimate and the bars were completely above the 1.0 line, then we would know there was an increased probability of prescribing. So we looked at those point estimates at 3 periods, during Module 1, during Module 2, and during Module 3, and then during the sustainability period. And what we see is during Module 1, we started to see some decrease, and it was significant because there is no crossing of that 1.0 line of 4% in the probability of prescribing for all ARTI. During Module 2, it dropped all the way down to 14% lower probability of prescribing for all 5 together. After module 3, it started to creep back up to 9%, and in the sustainability period, it creeped up a little bit more to a 6% decrease, but was sustained over that 6-month period. Now, when we look at the compliers and the non-compliers, we essentially see the same pattern. You might think, well, why do you have to do all this communication stuff if people who weren't engaging at all had about the same result? This looks really, really different when we start looking at the condition level. So I want to share a little bit of that with you. So for viral ARTI, we saw a 40% decrease in the probability that there would be prescribing for URI or bronchitis after exposure to the DART-QI intervention. And we see that while it was not a significant decrease for non-compliers initially, like it was for compliers, by the end, they both had substantially decreased prescribing. So there is something to be said for individualized feedback reports when it comes to prescribing for URI or bronchitis. It did seem to have an impact. Now, looking at pharyngitis, the 2 groups are very similar and similar to the intention to treat analysis, where there was about a 7% decrease in the probability of prescribing. But if we move to broad spectrum prescribing for acute otitis media, we see that in the intention to treat analysis, overall, we were not able to decrease broad spectrum antibiotic prescribing with the DART-QI program. But when we do the sensitivity analysis, we see really different results for the compliers versus the non-compliers, with a 23% decrease in the probability of prescribing for the compliers and actually a 28% increase in broad spectrum prescribing for AOM in the non-compliers. Similar pattern for strep, where in the intention to treat analysis, we see a nice 34% decrease in the probability of broad spectrum prescribing for strep. This is pretty much all explained by the compliers because there was no change from baseline in the non-compliers. And we see the same thing for broad spectrum antibiotic prescribing for sinusitis. In the intention to treat analysis, a 42% decrease in the probability of prescribing antibiotics compared to baseline. But again, almost completely, actually completely the result of what was happening with the compliers, because there was no change in use of broad spectrum antibiotics for sinusitis among the non-compliers. What were our key findings? The DART-QI program did decrease the probability of antibiotic prescribing overall by 6% compared to baseline, and that effect was sustained at least for 6 months afterwards. If you apply that to national prescribing rates, this degree of reduction would correspond to 1.2 million fewer antibiotics being prescribed to pediatric patients across the nation. And for viral URI and bronchitis, by the end of the program, all of the participants had significantly lowered their prescribing rates, regardless of their level of engagement, a 40% decrease in probability in our intention to treat analysis. And we found that DART was probably the least effective for reducing the probability of overall prescribing for pharyngitis. When we think about what we found with broad spectrum prescribing, feedback reports alone were not enough to decrease use. When we look at exposure to the full DART-QI program, so the intention to treat analysis, we did see significant decreases in the use of broad spectrum agents for AOM, strep, and sinusitis. However, as you remember, in our non-compliers, we actually saw an increase, a 28% increase in broad spectrum use for those who were prescribing for acute otitis media. And we saw the probability of broad spectrum prescribing didn't change for strep or sinusitis among these same participants, the ones who were non-compliers. So with that, I'm going to open this up for any questions that you might have, and happy to answer them.
Thank you so much for a really interesting talk, Dr. Mangione-Smith. I'll remind everyone that I am watching the chat box, so if anybody wants to type any questions into the chat function, I will be able to read them out. And certainly you can feel free to unmute yourself.
I would love to start out. This is Maggie Moon, and I want to thank you for a really interesting presentation. And I actually don't have a question. I just want to thank you for making the communication skills part of that so very clear. Your examples were really stellar, and I think it will really help people sort of understand the difference between a productive conversation about this and a one that's likely to be unproductive. So it was wonderful, and I really appreciate it. Thank you.
Thank you.
Hi, Dr. Mangian-Smith. This is Julia Kim. Thank you so much for your impressive and elegant DART QI program. I had a couple of questions. One, I was wondering regarding the antibiotic feedback reports. Is that something that's integrated into EHR dashboards or something that is feasible to continue into day-to-day operations even beyond the funding for your program? It just seems like an amazing report, and would love to figure out if that's something that we might even be able to implement here. And then secondly, I would love to hear your thoughts about why there was such a discrepancy or with respect to the broad spectrum antibiotic prescribing with otitis media, why there was such an increase with the non-compliant group.
Sure. So first, the feedback reports. Jeff and his group did develop the feedback reports to be drawn from Epic data. They do have the code for generating the reports. And in fact, I could probably answer your question better in the next 6 months. I'm trying at Kaiser Permanente, Washington, to work with our Epic programmers to see if we can actually create that same dashboard that could be monitored on a regular basis by providers. And I also have an ulterior motive. We're thinking about trying to disseminate this trial into the adult world, and would like to be able to generate the reports easily from Epic to look at our data. So our hope is that Jeff says, oh, sure, that's possible, but you never, the proof is in the pudding, right? We'll see how possible it is when we put our informatics people on it. Yes, it should be. You should be able to build a dashboard for it. And I know that Jeff, within the Children's Hospital of Philadelphia network of pediatric practices they have built it. And I think they do look at these data pretty regularly, and their providers can look at their own scoring pretty regularly. The other question, why do we have that wonky increase of 28% increase in probability of prescribing? So it was really interesting. When we were done with the study, I had the opportunity to go to the AAP, and all the PROS providers get together, or at least pre-COVID, they were getting together to hear about studies that had gone on in the network. And we had several of the people who had participated in the trial at that meeting. And we had a couple of the non-compliers. so we got some live feedback about, why that might have happened. What I would boil it down to is, I think one of our key hypotheses is that they just didn't trust the reports. Many of them really questioned the validity of the reports. And even when Jeff and his group would have a conference call with them and say, well, here's where we pulled the data, and these were the dates, and yes, they were your visits. And, there just was a lack of trust that the data were accurate. They were people at baseline who already were doing a lot of broad spectrum prescribing. So we tend to be comfortable with the agents we use, I always, have had here's my first line, here's my second line. I mean, I can rattle them off really quickly for you. And I think most pediatricians are like that, and we do tend to, it's hard to break old habits. So I think that was part of it. Their baseline broad spectrum was higher, among the non-compliers, and there was a real lack of trust in the reports we were giving them.
Thank you so much for answering those questions. A few more have come in through the chat box. One question from Dr. Dover. Although not in your study, is the prescription for antibiotics higher in emergency departments or walk-in non-continuity clinics?
So I can only reference studies that have been done looking at that, and the answer is yes. I mean, there is more prescribing in general for the 5 ERTIs in those settings, especially urgent care. That has been an Achilles heel for all of us, and who are trying to do work in this area, but not something that I have specifically studied.
Thank you. Another question from Dr. Dunlop. In the adult literature, incorrect or outdated allergy labels play a large role in antibiotic overuse or misuse. Was there any role in this pediatric study?
So you weren't eligible if you were listed as having, the encounter wasn't eligible if you were listed as having an antibiotic allergy. And I completely agree with you. I think there are many people walking around with that label where it's not real. And that does really influence our ability to do first line narrow spectrum prescribing.
Awesome. Thank you so much. Well, I don't see any more questions, but thank you again, Dr. Mangione-Smith. Really a wonderful presentation, really amazing work that you've done out there. I really appreciate having you here for Grand Rounds this morning. Hope that you have a great rest of the week. And to everyone, we will see you all next week for our next Grand Round session. Take care, everyone.
Thank you very much. Bye.